Today's webinar is on immunosuppression in CKD, presented by Dr. Sinead Stoneman. This will be a small talk with short questions and answers at the end. Thank you very much.
I hope everyone can hear me. Thank you very much for the introduction and for the invitation to present on behalf of the Pharmacy Services Committee on immunosuppression in CKD. We had highlighted, I think this has been highlighted as an area that people thought would be of benefit to talk to the community pharmacists and a wider audience at this talk and look at coverage by BC Renal, common drug interactions, immunosuppression dosages, changes and when they happen, cover some common misconceptions about immunosuppression, vaccination, complications, briefly talk about belimumab, and then answer any questions or comments that people may have in response to the talk. So thanks very much. So thinking broadly about who in British Columbia has kidney disease and is on immunosuppression, I think broadly they fall into one of three categories. They have glomerular disease, for which immunosuppression treatment is warranted, and that's a form of kidney disease. And this immunosuppression is covered by BC Renal. And then obviously people who've had kidney transplants for kidney failure or a pancreas kidney transplant for complications of diabetes or other organ transplants may have some form of kidney disease. Obviously, patients who have a kidney or kidney pancreas transplant have kidney disease by definition, but immunosuppression itself can cause kidney disease and other complications that can affect the kidney or vascular disease itself. And that immunosuppression for those groups is covered by BC transplant. So the focus of this talk is really on immunosuppression in glomerular diseases. This is covered by BC Renal. And thinking about the numbers in the province, 4,006 patients was a cumulative incidence of all glomerular disease diagnosed by kidney biopsy over 21 years until 2020. So the prevalence in BC might be slightly lower, and not all of these patients will be on immunosuppression at every stage in their life. But immunosuppression is the mainstay of treatment, in addition to optimized supportive care with RAS inhibition and SGLT2 inhibition, which Dan had discussed at a previous session. So we're thinking about the treatment and care as healthcare professionals we provide to this group of patients receiving immunosuppression for management of glomerular disease. So to give some context, what do I mean when I say glomerular disease? So it encompasses a group of relatively rare immune-mediated diseases characterized by damage to the glomerulus in the kidney. We can detect or suspect glomerular disease with the presence of protein or blood in the urine or decline in kidney function noticed by EGFR decline. We diagnose glomerular disease with kidney biopsy. And then once we have made a diagnosis, we typically focus on treating glomerular disease with immunosuppression to modulate B cells, T cells, or have other immune effects to reduce inflammation in the kidney. The content of the lower part of the slide is not, the detail is not necessary, but it's just to give a kind of broad overview of the treatments that are available for the subtypes of glomerular disease. Some of these conditions may be not familiar to a non-nephrology audience. These are conditions like IgA nephropathy or membranous nephropathy are glomerular diseases that act only in the kidney, whereas other conditions like lupus and ANCA vasculitis we may be more familiar with because they're systemic autoimmune conditions. But the immunosuppression that we treat these conditions with is generic. The immunosuppression that is available to treat glomerular disease is at the moment is not specific to these glomerular disorders. These are medications that we can use for all different types of autoimmune conditions. But this kind of treatment options for these subtypes of glomerular diseases based on the most recent international treatment guidelines, and these medications are covered by BC Renal. So just to give a context to glomerular disease. And I suppose within the overall remit of providing coordinated care for patients with kidney disease living in the province, in 2014, BC Renal developed a provincial GN drug formulary that improved patient access to immunosuppression treatments for glomerular disease in a cost-effective manner. And we know from a 2014 survey among Canadian nephrologists that access to immunosuppression through coverage was a challenge for patients that 84% of nephrologists reported. So the BCGN formally provides centralized funding for immunosuppression medications for patients with GN, providing equity so that access is not a problem for medications that are needed for disease treatment. And the GN formally funds immunosuppression medications for patients registered with BC Renal following submission and approval of an application. And oral medications are typically dispensed through McDonald's pharmacy. And I suppose thinking at the patient level, why we treat glomerular disease, it's a common cause of kidney failure, accounting for 10% of patients living with kidney disease in Canada. It has a high risk of death, both from kidney disease itself, but also from complications of treatment. And it has significant impacts on patients' quality of life. So they're all very clear reasons why glomerular disease needs good treatments. Oops, sorry. And then at the population level, we live and work with a publicly funded healthcare system. There are costs to the system from kidney failure and environmental costs as well. But we've seen over time that costs of immunosuppression treatment for glomerular disease are increasing, and this has been typically driven by mycophenolate and calcineurin inhibitors, but more recently by rituximab. So having a coordinated system for immunosuppression is useful for individuals, for managing the disease itself, and at a wider population level. To give some framework to how we think about immunosuppression in glomerular disease, there's lots of similarities with immunosuppression management in transplantation. There's a period of induction after diagnosis or after relapse when patients typically get a higher dose of immunosuppression to get the disease into remission and minimize progressive kidney scarring and the subsequent risk of kidney failure. And we try to balance that with the long-term risks of immunosuppression. Some differences are that typically when patients achieve remission in glomerular disease, the medication can be slowly tapered and sometimes discontinued, whereas that's typically not a common option in transplantation. And then transplantation typically uses 2 or 3 drug regimens, which we sometimes use in glomerular disease, particularly for things like lupus or ANCA-vasculitis, but more commonly 2 and 3 drug regimens are for more complicated or resistant disease. So patients compared to transplant have shorter and lower doses of immunosuppression. But that's not to say that they don't have risks of immunosuppression. And I suppose we use the same principles of evaluating patient-specific risk factors when choosing immunosuppression and anticipating drug toxicity so that we can mitigate those risks. In the interest of time, I've just included drug interactions that should be completely avoided in red, and those for which therapy modification should be considered in orange. Febuxostat is contraindicated with azathioprine due to the risk of severe myelosuppression, and allopurinol, if it is used with azathioprine, should be at a 2/3 to 3/4 dose reduction, given the risk of myelosuppression. Atorvastatin should not be used with cyclosporin, and pravastatin or fluvastatin should be used instead. And lercanidipine increases the risk of cyclosporin toxicity and should not be used. Then for tacrolimus, there's interactions with carbamazepine, clarithromycin, fluconazole, and I suppose in the interest of time, there's an excellent document available on BC Renal about major drug interactions with cyclosporin with tacrolimus by drug class, and I'll put the link in the notes at the end. But if this is a very handy document to appreciate the multiple risk interactions that can occur and how best to manage them. Then thinking about when a patient might come to mention in the pharmacy that their medications have been changed and when typically that happens. So this would often be during disease remission. So there's different definitions for this, but this is typically when proteinuria has significantly reduced and we're not worried that the disease in the kidney is active. When this has been maintained, we can slowly taper immunosuppression. And we typically taper cyclosporin and tacrolimus first to avoid long-term nephrotoxicity. If a woman is planning pregnancy, MMF and cyclophosphamide are unsafe for pregnancy and she'll likely be switched to azathioprine. Um, and then if there's, in the rare event that there's progressive scarring, such that immunosuppression carries a risk of complications, but without clear benefit, if a patient has progressive advanced chronic kidney disease, immunosuppression in that circumstance may be tapered and stopped if there's no benefit to continuing immunosuppression. Sometimes in severe infections, frequently immunosuppression is held temporarily, but often that will be in consultation with the treatment team or if the patient is in hospital. But that would obviously be another reason why immunosuppression is held. But dosage changes would typically be in one of these three circumstances. And then thinking about misconceptions about immunosuppression. Immunosuppression is obviously a high-risk medication. There's no getting away from that. And on the one hand, we're balancing the need for treatment, but we're also trying to think about the long-term risks of infection, cardiovascular disease, cancer, increasing patients' risk of death. And we also have to be cognizant of the potential risk of calcineurin inhibitor nephrotoxicity, though this can be safely lowered with careful drug monitoring and tapering medication where possible. And I suppose this is the dynamic processes, and that we want to think about the short-term risks, but also think about the long-term benefits and also the long-term risks. So it's a careful decision-making process. But I think one misconception I probably had earlier in my career was that this was a uniform risk. And I think BC Renal gives a great model of how the risk patients face can be mitigated. This is through patient education and patient handouts being a small part of that. There's the multidisciplinary kidney care clinics with integrated specialist nurses, and pharmacists also help with education and making sure that we do the basics of treatment well, such as drug monitoring, vaccination, secondary prophylaxis to mitigate that risk. And there are also provincial guidelines that give clear recommendations about mitigating risks with immunosuppression, such as appropriate use of PJP prophylaxis and mitigating gonadal toxicity and monitoring for bladder cancer malignancy after cyclophosphamide. So immunosuppression is risky, but there are ways that we can mitigate that risk. And I suppose another misconception similarly would be about its use in the elderly and that it should always be avoided. And similarly to the previous slide where we think about immunosuppression as a dynamic process, we can safely and appropriately use immunosuppression in the elderly, balancing clinical need, patient factors such as frailty, as well as monitoring patients over time to see how their clinical and frailty status changes and adjusting immunosuppression appropriately. So they were kind of two common misconceptions that I probably had, and through working in the GN clinic, I've seen how they can be mitigated and balanced. Then thinking about vaccination as a very vital way of mitigating risks of immunosuppression. A lot of the next few slides is based on the Canadian Immunization Guide, which recommends that appropriate routine vaccines or boosters should be administered before the initiation of immunosuppression. And in the real world, that's not always possible when someone presents acutely. But non-live vaccines ideally should be administered 14 days before immunosuppression initiation to optimize immunogenicity, and live vaccines should be administered 28 days before immunosuppression initiation to reduce the risk of disease caused by the vaccine. Adults on immunosuppression face a higher risk of influenza-associated complications and should have annual immunization with a non-live influenza vaccine. And because of the risk of prolonged and serious COVID infection, should have 2 COVID vaccines per year. They have a higher risk of pneumococcal disease and should have vaccination with the 23-valent pneumococcal vaccine. And adults over the age of 75 should have one-time administration of the RSV vaccine. Live vaccines are contraindicated for those on immunosuppression. There's a exception being the Mpox vaccine, which can be considered because it's a non-replicating live vaccine. And non-live travel vaccines can be used if indicated for patients on immunosuppression. Live vaccines are contraindicated for patients on immunosuppression. briefly on COVID, the highest risk of severe COVID was seen with rituximab, cyclophosphamide, and mycophenolate. In terms of COVID infection, reduced antibody response has been seen in patients receiving rituximab. So typically, we try to time COVID-19 vaccines 2 weeks before the next rituximab administration where possible. And similarly with other recommended vaccines on patients on rituximab, seroconversion and seroprotection is reduced. So we recommend that ideally these vaccines are timed 2 weeks prior to the next rituximab. We know that glucocorticoids increase the risk of infection, but we know from British Columbia that it's not just typical infections that we should be worried about. This is British Columbia data that shows that active TB incidence was 23 times higher in a population cohort of adults with glomerular disease in British Columbia. And at the time of diagnosis, 80% had received some form of immunosuppression previously. And probably something that we hadn't recognized well previously was the increased risk of cardiovascular disease from immunosuppression in adults with glomerular disease. And exposure to calcineurin inhibitors 4 years previously, and also exposure to cyclophosphamide within the prior 2 years, significantly increased the risk of cardiovascular events in this population. Belimumab is a novel monoclonal antibody to BAFF that has been proven to have efficacy in treating lupus nephritis in a large multi-center phase 3 trial and has been approved for funding by BC Renal. From an interaction perspective, live vaccines are contraindicated, but it has no interactions with commonly prescribed medications. So it's a kind of exciting new potential therapy for lupus. And hopefully just stuck to time, but happy to answer any questions or comments if people have them regarding this area.
Yeah, so we'll open up it now to our question and answer section. You can go ahead and submit your questions in the chat or the question and answer section in Zoom. Currently, we do have one here. Could you comment about SGLT2 inhibitor use and immunosuppression?
Well, thanks very much for the question. I mean, SGLT2 is a part of standard of care therapy for chronic kidney disease. So we often use them in combination with immunosuppression. There are two subgroup analyses of the large SGLT2 inhibitor trials that looked at SGLT2 inhibitors in glomerular disease, and they were very efficacious, but they weren't typically co-prescribed with immunosuppression. But in reality, particularly in non-diabetics or patients who do not have increased risk of urinary tract infections, patients can be safely prescribed SGLT2 inhibitors with immunosuppression, with careful monitoring if they were to develop fungal or other urinary tract infections. But in experience, most patients manage medications very safely, and there's no problem with their co-prescription in general.
Okay, thank you. We do have another one here. You mentioned CV risk with IS. Which events were seen more often, and how did it make a difference for those with previous events and those without it?
So I believe in this study it was a composite cardiovascular event. So I think there was acute MI, peripheral vascular disease, stroke, and cardiovascular death. I don't recall which was the most common outcome. I believe it was acute MI and death, but I might post the link to that paper as well. I don't think that answers your question very well, but something that we're increasingly recognizing. They were able to adjust for traditional cardiovascular risk factors as well as glomerular disease subtype and non-traditional cardiovascular risk factors like proteinuria and reduced eGFR. So we can tell that it would seem that the immunosuppression in itself is also increasing the risk of cardiovascular events. And I suppose that makes us more cognizant of making sure we choose the right patient for the right drug at the right time and think about obviously we need to make sure that we treat patients appropriately, but there may be times when we can reduce risk of we can start to taper medications and also make sure that we adequately address cardiovascular risk factors in clinics, make sure that patients are um, appropriately co-prescribed RAS inhibition, SGLT2 inhibitors, have lipid monitoring and are on cholesterol therapy as appropriate. I believe the plan for the research is to look at more specifically at risk prediction tools so that we can better identify patients at higher risk. Um, but I think it's also a reminder to us as a community to make sure that we adequately address, lifestyle, pharmacologic, and other ways that we can manage cardiovascular risk in patients.
Okay, thank you very much. Another one here we have, you talked about patient education as an important factor for immunosuppression risk balance. What can us community pharmacists help with when patients refill or fill their medications?
That's a great question. So I suppose asking the patient if they had specific concerns, you may be able to go through their medications with them. There are medication information leaflets available on the BC Renal website that we can also link to that give helpful, commonly asked questions that patients may have. Um, um, and I suppose every time I see a patient, I look at their medications and see what they need to continue. And if anything jumps out at me, and I think that as community pharmacists, you have a vital role in that respect as well. Um, um, I don't know if that answers your question specifically, but I think it's in collaboration. But we'll see patients very briefly, but during that interaction, we have an opportunity to give advice or answer questions that they may have. So, um, with your knowledge of pharmacology and of the patients themselves, that may be a huge benefit in educating patients.
Okay, great. Another question here. Has the BC approach to coordinating GN care resulted in less patients going into dialysis than before?
It's an excellent question. Now, I could be wrong, but I don't believe any data has been published on
Yeah.
that I'm aware. Um,
Yeah, I believe there might not be data for that yet too.
I don't believe there is. I mean, personally, I feel that coordinated care is probably the best way. We have great medications, but we also, I think, you look at any aspect of medicine, providing coordinated care to patients and doing the basics well is really always beneficial. If you look at acute stroke, other aspects of kidney disease, it's always beneficial. But I'm not aware of any data that proves that definitively. Um, um, but I could be happy to be corrected if I'm wrong in that respect.
Yeah, thank you there. I will just put one more here, just the last one. Are there over-the-counter products or supplements patients should avoid while on immunosuppressants?
Um, Generally, I think we would say that most over-the-counter supplements are um, are fine to take. The the cyclosporin and tacrolimus, I think there's so many interaction. There are interactions with antibiotics, and thinking also particularly about acute medications like clarithromycin, particularly with tacrolimus and cyclosporin. Um, they would be things that would make me worried that the tacrolimus levels are going to change acutely. But as to kind of cold and flu preparations or things like that, I don't believe there's any contraindication from that perspective. And if there was concerns, the KCC team or nephrologist will be happy to be contacted. Or as I said, that handy guide on the BC Renal website is also another um, point, excellent resource.
Awesome. Thank you very much for that. We'll just give it a few more seconds here to see if there's any more questions, anything that may come in last second here. Doesn't look like we have any more questions coming in. So, with that, I believe we can just end here. Thank you, everyone, for your time. And thank you again, Dr. Sinead Stoneman, for presenting. Thank you very much.